Hello and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to utilize some papers from the International Journal of Osteopathic Medicine, as I've done many times, just to try to talk about some general stuff that I think has value. So, with respect to attempting to figure out the rates at which osteopathic interventions seem to have some impact, one of the things that you can do is you can standardize a general approach that multiple experimenters will use, or one experimenter will use on many people, and you set some measurement such that you can see how often that particular thing that's standardized and applied ends up with a particular form of result. You'd want to do something really simple at first, a really straightforward, kind of rough measurement, and figure out how often it happens. So the easiest thing that you can do is figure out if there's change in range of motion. If you prefer to use a subjective measurement, you can do things like how often somebody reports a change in sensory state, so how much sensation they feel. You can do something like see how often a particular method as applied to multiple people will change a particular thing like heart rate and blood pressure. You can choose relatively straightforward measurements and see how often they end up changing, such that if they change on that measure at some knowable rate or identifiable rate, you can see if you should investigate it more in a larger group of people. You can then also consider whether or not that particular measurement, if it doesn't show much signal, is worth continuing to consider as something that you're targeting with a particular method. So you can figure out from a pretty simple, straightforward approach whether or not the thing does what you would hope it would do, or how often it does do what you would hope it would do. So I'm going to look at a paper that I missed. Where in the heck did we go? There we go. This is from 2025, so it's September 5th, 2025. The title of the paper is A Prospective Observational Cohort Study of a Standardized Osteopathic Maneuver for Chest Pain Relief. Garrett B. Gianeschi, I think, if I'm saying that properly, Sarthak Patel, Patrick Hinfey are the authors. So I have the abstract available to me. Is the full paper? The full paper is available. I'm not going to read the full paper. I'm going to read the abstract because I'm trying to get to a general concept. And note that I missed this, and while I missed it, it would have been valuable for me to have seen, because it does line up with something that I think osteopathy can do a good job from sort of bedrock, first principles, base work. Instead of looking at population data for the measures osteopathy has already suggested it could affect, and finding out that it doesn't, first find out what it does affect, then look at the larger population set for that. So if you look at an epidemiological approach in osteopathy, you're going to find mixed results. You're going to find studies with high risk of bias. You're going to find studies that aren't particularly powerful because the sample size is too small. That doesn't mean that there is nothing there. It just means that based on the hierarchy that is being evaluated of the evidence that is presented, it doesn't match the values in the hierarchy that are pre-existing. So instead of looking at large data sets or large population data with respect to hands-on therapy, it might be smarter to start from a base level and figure out what the heck these hands-on therapies are doing, what measurements they are observably changing, and then transition into doing those measures on a larger scale to see if you can identify any characteristics that would make somebody more likely or less likely to respond to the intervention, with the caveat that just because they fall into one category that would make them more likely doesn't mean there isn't another category that has been unexplored that would make them just as likely to respond well when compared to the characteristic or the characteristic that you would think, as it has already been studied, that would preclude them from being a good candidate for that approach. So anytime you have population-based data, you have to be careful because it depends on how the groups are aggregated. It depends on what's being measured. And only under the circumstances that those things match appropriately with all of the unmeasured categories about an individual, or all of the unmeasured observable markers that are unmeasured, that those all match. Therefore, I kind of know what I want, know what I'm looking for. So just something to consider. Anyways, I'm going to read the abstract. Chest pain, CP, is a common and challenging complaint in the emergency department, often requiring rapid assessment to rule out serious conditions. While medication-based treatments are frequently used, there is a growing need for alternative therapies, particularly for non-cardiac chest pain. The sternal brace, an osteopathic manipulative technique, may serve as an adjunctive therapy for chest pain in the ED, the emergency department. The objective: this prospective observational cohort study aimed to explore the effect of the sternal brace maneuver in reducing CP of any etiology in ED patients. So just know that anytime somebody comes in with chest pain, regardless of how it started, they decided where available that they would attempt to apply this, regardless of the etiology, because what they're doing is they're looking at chest pain as the category, regardless of how it got there. So when chest pain comes up as a category, does this approach do anything to it? The methods: data were reanalyzed from 34 adult patients presenting with CP at Newark Beth Israel ED. The numerical rating scale was used to measure pain levels before and after the maneuver. Patients were classified as responders if their NRS decreased. So remember, the category is chest pain. Pain must be reported by the individual. There are proxies that are observable from outside of the person, but they're not as trustworthy. So the report of pain is the good enough signal that it is present at the intensity that they say it is present at, because you will have differences between what the practitioner thinks they're finding as far as mechanical dysfunction and what they assume the level of pain the patient may have would be based on previous experience. But those things don't match up neatly. It's not a good way to do it. This sounds dismissive. It's not meant to be dismissive. But the report of intensity of pain that the patient presents you is a good enough measure, because they have to tell you how they feel. You can't detect it. You can detect things. You will see situations where there's a level of pain reported that's low, and then when you see the findings of whatever you're measuring, you assume it should be higher, and you'll say things like, I don't even know how you're walking, stuff like that. So that's because pain as a marker is a variable between individuals and with an individual, and it won't always match your broad experience with a bunch of different people that aren't the current person. So look at results. In 34 patients presenting with CP, chest pain, the maneuver led to a statistically significant average reduction in pain of 1.32 points, 18.5%. Disease score is 3.124, P of 0.009. Just really, really superficially, the number of people, for that to be a really, really strong statistical measurement is tough. So if you were to look at this from an epidemiological standpoint, there's nothing here. I need to see it on 34,000 people, but it's good initial signal. The initial signal tells me that this would be worth studying more, because with a non-pharmacological intervention, I can alter the report of pain in an individual with something that's probably low effort, and it's low cost too. So in an emergency department, that would make a big difference, and it's probably quick. Let's put it this: 38.2%, 13 out of 34 were classified as responders, experiencing an average NRS decrease of 3.7 points, which is a 64% decrease. The remaining 61.8%, 21 of 34, were non-responders. Subgroup analysis showed decrease in non-cardiac CP was 1.5 points, 21.3%, while cardiac CP decreased 0.9 points, 12.7%. No major adverse outcomes were observed. Conclusion: the small study suggests the sternal brace provides modest effectiveness in pain reduction in ED patients with a chief complaint of CP. So the category of chest pain has multiple other factors related with it. So like they said, this 34 people, regardless of etiology, if you classify them as chest pain, you're aggregating a lot of other factors into one. So depending on the etiology of the pain, there may be another thing that would be more powerful to alter that pain versus this hands-on manual therapy. So what you would do, so there's a signal here, there's some signal. You would run this on a larger data set, and you would analyze the etiology, or the currently identified etiology, because it may not be the ultimate etiology. It may just be the currently identified one, such that you have a new category that could separate it out, and you could see the new categories, the wider range of categories whereby people were more likely to respond to this method, such that in the diagnostic process, if you can fit people into the 2 or 3 categories that respond best, or so, they have chest pain, it's non-cardiac, and it is subsequent to novel physical activity, something like that. You have 3 categories. You end up with an approach that could allow you to figure out who this would be most appropriate for, so you can go ahead and apply it. Whereas if it's not appropriate, you have a really good idea starting because they don't fit into all those boxes. You need to examine for other interventions that would target the chest pain better. But they've done something whereby they took one category, they applied one method, and they saw the rate at which it works. They got some signal such that they can go forward and try to figure out in a more granular way what would predict or what would make me willing to think that this is a little bit more likely to be an appropriate method under the circumstances in an emergency department, where I could have this low-cost, quick method to alter chest pain for at least a short period of time without needing drugs, right? So it's an interesting thing. I applaud them for doing this. I think it has value in studying more, and other things could do a good job of copying this basic concept. So you can literally build a framework off this. There's a diagnostic category that we want to investigate the application of a single osteopathic intervention and see the rate at which it works. Well, the retort to that is, well, that's not osteopathy, because osteopathy is unique to the patient in how it's applied. And you're correct, but you can at least build something so that you know how often the tools are likely to work, like a specific tool, specific approach, and then you can add your individual variants onto it. That would be totally fine. That's okay. There's no problem with that. And you can study this in different ways, but this is a really good way across an entire field of manual therapy where you can get fundamental measurements so you can figure out where to investigate more or how to predict who's going to be most likely to respond positively to the intervention so that you can shift to other interventions quicker, more effectively, more efficiently, because you now understand the patient on a slightly different level based on diagnostic discrimination. The term discrimination being the ability to determine something that is from something that is not. So something that is a thing from something that is not that thing is a really quick, rough way to talk about the process of discrimination, especially within diagnostics. Diagnostics have to be discriminatory. I can't treat you for everything, because if I did, I might kill you. I need to treat you for the thing that you most likely have. Now, I'm going to switch over here to an article in Press. This is March 4th, 2026. It's a pretty short abstract. I've spoken about this before. Artificial intelligence. I don't like the term artificial intelligence. I prefer the term large language model because for the most part, that's what most people are interacting with. This is called a short communication. The article is titled Exploring the Utility of ChatGPT as a Learning Tool in Osteopathic Medical Education. Patrick Martin, Neil Pate, I'm not going to pronounce that because that's easy to screw up. Iman Benmerzuga are the authors. Hopefully I said that properly. The abstract here to read. Artificial intelligence is increasingly being integrated into medical education. That is true. I've been around discussions at McMaster University with respect to the integration of large language models into the educational side. I have seen some stuff. So one of my thesis committee members, Dr. Matthew Sibbald, was the primary on an article about the integration of an artificial intelligence diagnostic tool, which is called Isabel. It's an acronym. I don't remember what it stands for. And they were observing whether or not it was useful to bring it in early, bring it in late. I don't remember the results of that. But so I've seen some of that. I've been proximal to some of that. It doesn't mean I'm an expert in it, but I've been close to it. I've attended a conference on artificial intelligence within medical education. There were multiple presenters and facilitated discussion groups. One of the things that seemed most consistent at the time, and that would have been, I think that would have been the fall of 2025, if I remember right. I might be wrong. It might have been a different time, but it might have even been the spring of 2025. I don't remember, but the thing that seemed to be going on there was that people who already know stuff seem to be able to leverage large language models to think with them instead of think for them. You want to be very careful in that population that is using it to think for them because they are not developing the cognitive skills remembering the details, building the semantic network or the network of related meaning to be able to detect when the large language model is incorrect. So my argument is when you use AI or large language models, you're robbing yourself of skills, knowledge, and experience. So that's just a little bit of preamble here. While ChatGPT, chat generative pre-trained transformer, has demonstrated the ability to pass standardized exams such as United States medical licensing examinations, USMLE, steps 1 through 3, and outperform some medical students on clinical reasoning questions, its utility for osteopathic licensing remains unexplored. So something I'm going to say is, if more people do something, if there are more resources around a thing, in some electronic device or in some large language model, some statistical prediction device, if it has more data, its ability to predict what's going on is better. It's trained on more data. There's far likely way more USMLE data hanging around in various parts of the internet than there is COMLEX data. So that is something to consider with what their findings end up being. And also, one of the things to consider is the version of ChatGPT that they used. But either way, they probably haven't looked at COMLEX a bunch. If they looked at COMLEX more, you might see a different result, but maybe not. I do not know. Anyways, this study evaluated ChatGPT's 3.5 performance on 113 multiple choice questions sourced from the comprehensive Osteopathic Medical Licensing Examination, COMLEX USA Level 1, COMLEX Level 1. They just shorten it up, don't worry about that. Practice materials, and 2 physiology textbooks. Ganong's Review of Medical Physiology, 26th edition, and Case Files, Physiology, 2nd edition. Questions involving images were excluded. ChatGPT was prompted to select and justify answers, which were then evaluated for accuracy. Results showed that ChatGPT correctly answered 56% of COMLEX Level 1 questions, including only 33.33% in the Osteopathic Principles in Practice OPP category. In contrast, it achieved 82.35% accuracy on questions from Ganong's and 58.82% on Case Files, with a combined textbook accuracy of 77.65%. These findings indicate that while ChatGPT can effectively support physiology learning, it currently lacks the precision required for COMLEX Level 1 preparation. Future studies should explore model refinement, command optimization, and enhanced integration with osteopathic-specific resources to better support osteopathic medical students preparing for board examinations. The conclusion portion, I'm going to have a little bit of trouble with. That's okay. It doesn't mean anything negative. It doesn't mean that I'm right. It doesn't mean that they're right. It just means that I have a disagreement. As far as, say, if your target is to continue to use large language models, then their conclusion is the accurate one. It is the way to go. Make this thing better. What I would say is that the amount of printed information available about osteopathic principles in practice, OPP or OMM, or whatever you want to say, or probably OPP, because OPP would be the written, OMM would be the hands-on. The amount of written material available, especially that people would use as a resource to test from, is likely exceptionally low. So the ability to build a statistical prediction based on that may not be as good. Now, there could be an argument that it would be better because there's less to compare and contrast between, so the answer should be more obvious. I'm not necessarily sure how to square that because I don't properly know how the training data would interact with the output. I'm not sure. So that's at least a possibility. Whereas with respect to USMLE, there's probably been way more people using ChatGPT. Now, this is 3.5. It's an older version. I believe 5 is out. That doesn't mean it's better at these things. It just means it's probably had more refinement in particular ways. And maybe the training data has increased. But there's probably just way more people giving feedback and using ChatGPT as a backbone for research, for testing purposes, for studying purposes, for USMLE than there is for COMLEX. So it's probably far less trained. What I would say is that you have to make the assumption that using AI or using a large language model is a useful thing for practice, because one of the things that you're doing here is you're really talking about the test, passing the test. Students over time with board exams, especially a series of board exams, have already proven that they can find ways to pass that test. The test is not the end goal. The test is the proxy that I believe that this person is safe to practice with the general public. So should I be optimizing for the test or should I be optimizing for practice? I would argue it may be more valuable to optimize for practice. What's the way to say this? One of the things that you will find is that when people get good at doing particular things, that's what they're optimized for. They may not be optimized for something else. So when you get students who are high achievers and really want to get to an end goal and they want to get through the process of becoming a regulated professional with multiple board exams across time for multiple reasons, that they're going to get really good at tests. Now, being really good at tests, at least currently, is essentially background noise for those who end up entering clinical practice and end up doing a good job. It's background noise. It's already there, so you're not sure if the ability to pass those tests is the reason that they're good physicians, or is it the knowledge that they are able to retain? Is it the skills that they build? But one would be tempted to say that the ability to pass the test then predicts medical practice. One of the only things that I'm currently aware of with respect to predictive value of the results of licensing exams is those who score higher tend to have less malpractice lawsuits across a career. That's the only thing I'm aware of. It doesn't mean that there are other things. It doesn't mean that there are not other things that it predicts. So it could mean that there are other things that it predicts that I don't know about. But this article seems to at least point in the direction of attempting to optimize the use of a novel technology to pass a test. I would argue that there is more value in attempting to figure out how to get these people better observably in clinical practice. Now, it's a harder lift as far as research is concerned. It'll take longer to figure that out. It could be more complicated. You could have a harder time with gathering participants because these are going to be busy physicians at some point. But you would want to attempt to, as a hierarchy, consider trying to figure out how you can make somebody a better practitioner as opposed to make somebody a better test passer. Because if you teach these people to optimize for passing the tests, then it's possible that whatever that is hiding in practice maybe could be harder to find. But again, the only thing that I know is that those who tend to score higher on licensing exams have less malpractice. So you could use that one piece of information to argue that this is still a valuable thing, and if you get these people to get higher test scores, then whatever it is, whatever that magic mix is, they'll be less likely to have malpractice lawsuits later on across their career, and that might just be a fantastic thing. Just because you don't have malpractice doesn't mean you haven't made errors that have been harmful to patients, but it does mean that they haven't gotten to the level where a motivated person would not take legal action against you. So the thing that I want to say about this is simply that they're noticing a difference in the performance on osteopathic testing, or really the written portion of COMLEX versus USMLE. That could be the training data available, that could be something else. But also they are hierarchically suggesting, at least pointing in the direction. They may not have done this consciously, and they may not necessarily believe this if you asked them this, but they're trying to point in the direction of let's get some money and do some work on making these large language models better for helping students pass tests. Students already want to pass tests. They already find a way. You don't need to give them any more help. There's all kinds of courses. There's all kinds of books written. They find a way to get through. These are highly motivated, highly intelligent, highly skilled people. You don't have to help them get through. So making ChatGPT better at passing COMLEX doesn't necessarily mean that the student wasn't going to pass already. So I don't know that there's value in this based on currently observable trends. Smart students who do good on tests. People who want to be doctors are usually smart students who are going to do good on tests. They're going to find a way. They're going to jump through whatever hoop they have to. And they've been doing it for a very long time. COMLEX isn't new. COMLEX has been updated, which is wonderful, but it's not new. These students already get through this. They're already motivated. You don't need to give them a new tool to make it more efficient, to take the friction out of the process. What I will say is that while not an absolutely firm statement or something that I could immediately point at data to, I would predict that a little bit more friction in a process, a little bit more effort, a little bit more failure that's identifiable, or a little bit more error commission that's identifiable, seems to support the learning process broadly. There is a term, desirable difficulty. I don't know the underlying research about it well enough to say that I think you want to invoke it, but I can tell you that the term productive failure shows some pretty good results. So productive failure is failure when you know you did it and you learn something from it. So you can engineer for productive failure. A lot of that research, I think, started popping up in 2015. I do not remember the initial gentleman's name that did the majority of that work. It also would relate to what I was able to identify as an observation in my thesis, whereby those people who committed a categorization error and were informed about that categorization error removed that error in subsequent opportunities to commit the same one, whereas those who committed a categorization error and got no feedback on it would commit the same error again. So when it was an opportunity to do that, they would commit it again. So the ability to make an error, know about it, whether it is because you can tell as the individual who committed it or external feedback provides you with that information, seems to have important value. So I could then make the prediction or make the hypothesis that the terms desirable difficulty, the term productive failure, may be pointing at a similar phenomenon that ends up having value. So don't attempt to make passing tests easier on people. Let it be as hard as it already is. They're going to find ways to get through it. And in finding the ways to get through it, they're developing other skill sets that may or may not be transferable, but the ability to remember the information, embed the information for future use often would be argued to improve. It may not do it all the time, but you could at least make that argument and then test it. So 2 papers, one whereby I think the authors did a pretty good job of getting a basic measure of responders versus non-responders, such that there seems to be a general piece of information or an observation that some people will respond to a specific osteopathic method in an emergency room for chest pain, and then you could get more granular and figure out how to predict when that would be more likely, so then you could have a strong intervention for very little money. Then the other one, exploring the utility of ChatGPT as a learning tool in osteopathic medical education. I have qualms with it for a variety of reasons. I think nothing negative about the paper. I think nothing negative about their conclusion. If you agree that you should use this tool to help people pass tests. So I've already presented my thoughts on that, my arguments in the direction of that or against that. Take from that what you will. Hopefully you take something. So thank you for listening this far. Hopefully you've learned something, and we will talk again soon.